starting. All attendees are in listen-only mode.
Good evening. This is Dr. McSherry and Dr. Prusak. It is 9:06 p.m. on July 14, 2014. Tonight we have actually two case lists that we're going to review tonight. We have Dr. Deepali Kashyap, and then we have Dr. Valoria. And I'm sorry if your name is spelled incorrectly on the schedule. And I had the wrong faculty on for tonight too, so I want to apologize for that. But everything's straightened out, and we're going to go ahead and get started here. And Deepali, I'm going to go ahead and take you off of mute here. And Liz, I'm going to give you the mouse so you can scroll down, okay?
Perfect.
Okay, Dr. Kashyap, are you there?
Yes, I'm here. Can you hear me, Dr. McSherry?
Yeah, I can hear you just fine. And then Liz, let me give you the mouse.
Okay.
Okay.
Okay. All right, go ahead, Liz. Can you move it around? Here. You got it?
Great.
Okay. Okay, you guys are on. Go ahead.
Great. Okay. So what's your specialty? Are you a generalist or a specialist or what?
I'm a generalist.
Okay, so you do about equal OB and GYN?
Pretty much.
Good, good. Okay. And then how many cases do you have on each case list?
So OB I have 76 and GYN I have about 43.
Okay. You guys have a lot of cases on your case list. And, we always talk about, I'm not saying that you need to, you should put them all. That's what, that they tell you. But, that is really like a lot of cases to put on there, actually. And you know that the minimum, you just need basically the minimum. So just always remember that. Like if you need to omit any or anything like that, like don't be nervous. You have plenty of cases.
Okay.
All right, so we'll start off with the first one. So you have a 43-year-old G2P3 at 38 weeks, so she was IUGR and breech. Get rid of the 2-vessel cord.
Okay.
She had no delivery, increased fetal surveillance. Get rid of that. Primary cesarean delivery, that's good. Your baby weight looks good. 2 days in the hospital. So this is for under abnormal fetal growth. Okay, I get it. So what did you section her for? Breech or IUGR?
Breech.
At 38 weeks?
The IUGR, she was being followed and the IUGR was less than 10th percentile. It was progressively getting worse. So then CMFM recommended delivery. High-risk pregnancy center.
I got it. And then the same thing for the next case. You basically had a 26-year-old. She had one that was advanced maternal age, and the second one's a 26-year-old, also at 38 weeks. IUGR, what is this, like the same story about you getting worse, IUGR?
Yes. Yeah.
Okay, so get rid of increased fetal surveillance, and this one had good APGARs 8 and 9. Okay. All right.
Now, the reason we ask you to get rid of increased fetal surveillance, because I wouldn't mind if you put it in your antepartum column and put non-reassuring fetal surveillance or non-reassuring antenatal testing. That would be a complication that would lead me to believe that your Dopplers had reverse end diastolic flow and you needed to section her right away. Now, if you put increased fetal surveillance in the operative procedure, that's not an operative procedure or a treatment. So that's why I want you to follow exactly what the board is asking of you. They want you to put down operative procedures and or treatment, and increased fetal surveillance is not an operative procedure or a treatment. Do you see what I mean?
Yeah, it's an antepartum, yeah.
It's an antepartum evaluational modality. And then if like say she had reverse end diastolic flow or then you could put that in the antepartum column and just put it like, a non-reassuring Dopplers or something to that nature. I just want
and I almost think that Dr. McSherry is right. I kind of think that you probably should put that in the antepartum because, I'm right away, I'm like, oh, well, why did you section a 38-year-old? Breech, you let them go to 39. There's no reason to just because they're breech, they don't get sectioned at 38 weeks. So, and the IUGR can be, that's 39 weeks you induce them or section them. So why did these people only go to 38? They're real sticklers about the 39 weeks at the board. So I probably agree with her. I would put, non-reassuring fetal surveillance or something like that.
Yeah.
And then you can choose whatever you want, the Dopplers, the growth, whatever.
The fluid was low. You could put you could put oligohydramnios. Put a qualifier in there in the antepartum column to make it say like, hey, I had to section her now. I couldn't wait another week, you know?
Yeah.
And the kid didn't look right. The kid did not, the kid showed me that there was signs or evidence that this kid she may end up with an IUFD, right?
Okay.
So that's why you did it. Okay, sorry.
Agreed. Yeah, definitely. All right. So the next one, you got a 27-year-old GTP1 at 30, another 38 weeker for breach. I would put down breach, and you can put down labor. Next column. So you did a primary cesarean delivery. Okay, that's fine on that one. So now you have another 30. I mean, you're sectioning all these 38-year-olds. Okay. I mean, 38 weekers. IUGR breach. Prior cesarean delivery times 1. Again, the same problem here. Increased fetal surveillance. I mean, you're going to have to justify why you sectioned a breach at 38 weeks again. So I would say it's the same thing again. I don't think you have to put prior cesarean delivery times 1. I mean, when you put repeat cesarean delivery, that's going to be obvious.
Okay.
Okay?
Yes.
Other than that, it's looking pretty good so far. 25-year-old, primib, 39 weeks. Okay, good. You sectioned her for breach at 39 weeks. That's fine. Primary C-section, your weights look good. Days look good. Okay, so pulmonary disease. You got a G4P2 at 37 weeks. Okay. Asthma. I would get rid of GBS positive.
Okay.
None. Operative procedures, albuterol. So, okay, so this girl, what happened? She came in labor or what?
Yes. So she came in labor. She just had history of asthma. It was not severe. It was very well controlled asthma.
Okay, so I would put asthma, labor, and then under delivery none, and then you can put albuterol, and you can put SVD. So make sure that you read the practice bulletin on asthma, okay, because that's going to be something, if you have an asthma case, you've got to know exactly how to manage asthma. It's a kind of a complicated bulletin, actually, because it lists all the different medications and stuff. So I can't pull up ACOG right now because I'm looking at your case list, but, you know, just make sure and make a note of that.
Okay. Thank you.
All right, delivery complications. So you have a 40-year-old, G2P0 at 38 weeks. Okay. So for antepartum, okay, how did this patient, just present this patient to me because it's a little bit confusing. I think you just have the things in the wrong places here. What happened with this patient? She came in labor or what? Prom, what?
Yeah, so she's a 40 years old, gravid to para0 at 38 weeks, and she came in active labor, and she progressed very well until she was completely dilated. And then we had an arrest of descent at +4 station. So after...
Okay, so hold on, wait. Okay, so antepartum labor, okay, and then you can have under operative procedure, or I'm sorry, under delivery, that's where you put your arrest of descent, okay. Okay, I don't, oh, I see, bladder laceration. Okay, you had an unsuccessful vacuum trial. Okay, so under operative procedures, you can put unsuccessful vacuum, primary cesarean delivery. Do you know how to repair the bladder, which suture to use, how many layers to close the bladder in, which places that you have to...
Yeah. Actually, for her, I called the urologist to repair the bladder.
Okay, I know that, but you're still going to have to explain, like, even though that you can't do it, like, you're still, because that you put this on your case, you're going to have to, and the only reason I'm telling you this is not because I want you to take it off, but because, you know, you're going to have to read exactly which areas of the bladder that you have to do different repairs on.
Okay.
And you have to know it anyway, because the thing is that bladder injury is part of surgery in OBGYN. And so they're going to have to at least, you know, you might call a urologist to come and repair it, but you're still going to have to explain how to do it.
Okay.
All right. So you can put, you know, bladder repair if you want underneath there, but, you know, honestly, probably, you know, you're going to go down a can of worms with this bladder laceration, okay?
Okay.
So 6 days. So why did you say 6 days in the hospital?
She had the, you know, Foley catheter for a long time, and then urology was following her, so they just wanted to keep her a little bit longer. So the baby was discharged, but she had a little slow recovery. So because of that, she stayed a little longer.
Yeah, I mean, usually even when you have a bladder laceration, they go home with a Foley. So you're going to have to kind of explain, I mean, just be moving along slowly, you know, you can either say that she had, boy, I don't know how to explain 6 days. I mean, I think it's a little bit long just for a bladder. I mean, where was the bladder lacerated, do you know?
It was at the dome of the bladder, actually.
Okay. All right. Well, I would read up on bladder injuries, and I would explain it a little bit better than 6 days of that she moved along slowly. So, you know, I'll have to think about it. I don't know if Dr. McSherry has any other ideas about that 6 days thing. It kind of bothers me.
Yeah, why was she in the hospital for 6 days? I was sending a text message on my iPad.
Oh, that's okay. She said that she moved along slowly.
She moved along. So you mean that it was? What do you mean it moved along slowly? She was in labor for 3 days.
She was labor for almost
Are you
2
sure?
days. Yeah.
Then why didn't you start her on PIT then? Or you just kept her in the hospital? Or
No. You told me that she came in labor. So in antepartum, we're going to put labor, okay? And then we're going to put arrest of descent. So she arrested of descent. So then you did a section on her after you try to vacuum, right?
She came like one day in the evening, and then the delivery was next day. So that kinds of makes one extra day. And then normally they would stay for 3 days, so 2 days. So she stayed extra 3 days. Yeah, there was no other post-op complication. That was the only reason. Like she was like really slow at. But I can look at her chart again and.
yeah, I would take a look at her chart again.
Yeah, I mean, I can't think of a great, you could say, I mean, I'm just trying to think, like, why would well, okay, you could say a lot of different things. You could say that she had a post-op ileus or something like that. And, I mean, you can explain ileus because you're a surgeon, that's your specialty very well, and you can go on about how that, you backed her down to NPO, you gave her fluids, that sort of thing. I mean, that's, at least you have to have some sort of a diagnosis why that she stayed that long. And, saying that she had at least, I mean, I don't know if she did, like a post-op ileus would sound smarter than she moved slowly. All right?
I agree, yeah.
That's my opinion.
Yeah.
All right, so a 30-year-old G2P1 at 40 weeks. So, again, did she come in labor? I assume that she came in labor or prom. Put that there. And then under delivery, shoulder dystocia, and you can put vaginal delivery. I know that I think like in our last course, Dr. Wall was explaining that, if you have a shoulder dystocia, you really can't put SVD. It wasn't spontaneous per se. And again, this baby weighed 4309. The baby had 8-9 Apgars. Okay, that's good. Just make sure that you really know the shoulder dystocia protocol. So, I actually had that. They asked me shoulder dystocia on my test, and they ask you for every question, it's always describe the evaluation and management. So think about what you would say if the board examiner asked you, what's your evaluation of a shoulder dystocia?
You mean like antepartum?
No. Nope, you come in, there's a turtle sign, everybody's screaming, doctor, doctor, I think we have a shoulder dystocia. What's your evaluation? Evaluation and management.
I mean, first thing is you call for help, so you notify everybody, anesthesia.
No, that's management. You starting to get sweaty? Yeah. It's a little, so what I believe that they wanted, because they moved me along after I said that I would quickly review the patient's chart, because they said that you've never seen this patient before. So I said you would quickly review the patient's chart, you would check the vital signs of the mother, and then you would check the fetal heart tracing. And then they said, okay, now tell me your management. So it's a very thin line sometimes. You have to be able to distinguish evaluation and management. Okay, a G2P0 at 40 weeks. Again, she came in, I assume, why did she was labor or what with a primary cesarean?
She was labor.
Okay, and then I would say category 3 tracing.
Okay.
Okay, yeah. So use your category 3 tracings, and then that way they can ask you about it. Well, what's a category 3 tracing? And then you can look in, there's a couple bulletins that have it laid out very nicely. Again, same thing, labor, category 3 tracing, primary cesarean delivery. And then why did the baby have a 3 APGAR score?
I think it's the tracing, it was like acute hypoxia.
Okay. Did you do cord gases on the patient?
I did. I didn't write it here. It was...
No, you don't need to write it, but just be able to have some explanation about why a baby would have an APGAR score of 3. Okay, so now you're going to get into your diabetes here. So it's a 37-year-old G3P1 at 40 weeks. So she has gestational diabetes. She had a shoulder dystocia. What happened? Did she come in labor?
Yes.
Okay, so
you know, I'm sorry, but I'm not sure about this one, whether she was induced because of diabetes or labor. I'll have to check that. So do we need to write on every patient whether they came in labor or...
I mean, I did on my case list. I mean, I don't know. I mean, that's how that, you know, I had mine corrected by Dr. Wall's tutors and stuff. So, I mean, maybe, didn't Dr. McSherry, whenever you have a second?
Yeah, go ahead.
Yeah, I mean, I think that they should write some sort of either SROM, labor, something like that.
You can. If you don't want to put none there, you can put like, you know, a labor. You can put labor, but it's not really a complication. That's a normal active nature. So if you really don't have a true antepartum complication, a lot of people do put none, but some people don't like putting none. They want to put something there. You can put, you know, labor onset or just labor or active labor or...
You know what I think it did for me is the reason why I kind of did that, I'll be honest with you, is because when you're in the test, like they're gonna, you know, say, okay, go to case number 11 in your obstetrical list, and you're gonna be, you know, sweating bullets going down to case number 11, and then you're gonna have the story all laid out for you on your case list. Like your case list is supposed to be so easy that when you look at it, like you don't have to sweat it. Like you don't have to think, okay, how did it, okay, was this patient induced? Did she come in labor? And then you're starting to sweat it. And, you know, really you want to have a nice story so that it flows from left to right and you don't even have to think when they ask you.
Okay.
So, I mean, that's the only reason why I put it, because for me it was easy to read it. I said, okay, this patient came in active labor. She had gestational diabetes during her pregnancy. She was, you know, well controlled. So, you know, I would again take out increased fetal surveillance. She progressed very well. You know, she had a vaginal delivery that was unfortunately complicated by a shoulder dystocia. So that's how I would kind of describe that case. And then again, your same shoulder dystocia, know what to do with that. Okay, so you have a 29-year-old G5P3 at 39 weeks. Again, what kind of thrombophilia does she have?
She had the homocysteine, she was like homozygous.
I see. Okay, and she was on Lovenox for the pregnancy?
Yeah. She had that 367, yeah.
So I think for this one, I would go ahead and put the thrombophilia, which one that she had,
Okay.
and you can put on Lovenox, history of an IUFD at 21 weeks, take out the GBS positive, keep the none. I would put induction of labor and SVD.
Okay.
And she died. She progressed well when you induced her, I guess, it looks like?
Yeah. Yeah.
Okay. Make sure that you read the practice bulletin on the different thrombophilias, okay?
Okay.
Yeah, because you're gonna have to know everything. When you put a case on there, you make sure that you know everything about that topic. So you go to the practice bulletin or the committee opinion, or and you read all about it and you know everything, okay?
Okay.
All right, so we have a few more minutes with you. 26-year-old, 40 weeks, gestational diabetes. So, I mean, these I assume are all well controlled because they're being kept to 40 weeks, correct?
some of they are well controlled, but some of them are like A2 on insulin or glyburide.
Okay. Make sure that you, there's a committee opinion on in medical reasons for induction of labor, and they actually tell you all the different weeks that you can diagnose or that you should induce a patient with different medical conditions. All right? So make sure that you read that because, you have not any, you're not inducing her and that sort of stuff. So again, I would put none. You can take out the increased fetal surveillance, just put SVD. I guess the word diabetic care is okay. You had that previously. It's pretty good. The good thing about your cases is that you're not too wordy, which is good. Okay, a 38-year-old.
Yeah, listening.
I'm sorry,
to
what did you say?
That I've been listening to the
webinar. Yeah. It's good. And then Dr. McSherry also has I believe it's a case review coming up in Newark this weekend. That's also it's very good. You can get your case personally reviewed, but I think yours is pretty good. You have a spelling mistake here.
Yeah, it's good. She's doing a very nice job.
So just correct. Make sure you're spelling mistakes. So that's fine. You can put active labor. You can get rid of the prior cesarean delivery ×1. None is fine. Diabetic care, increased fetal surveillance, get rid of that. And then you can put down repeat cesarean. So she was at 38 weeks and she came in active labor, right?
Yes.
Okay. So that's a good weight on that. Good. Did you take away my mouse, Denise?
Yeah, just for a second. I was answering a question. We have a third person tonight that came up.
Oh, okay. So I think that your case list is good. Just make sure and correct your spelling mistakes. But I think it's pretty good, actually. You're on the right track.
Thank you. I have a quick question.
Yeah.
I have a lot of cases if we scroll down in like uncategorized categories. So is that okay? Because they really had like nothing going on, no antepartum, no postpartum complications. So is that okay that a lot of cases are really not in no category?
Where is this no cat? Hold on. Let me take a look here for you. You're talking about the ones all the way at the end here?
Yes.
Okay, just a second. I can't find it where it says uncategorized.
I'm doing it. I'm trying to find it.
Oh, okay.
That's why I took the mouse over.
Okay. I see. Okay. No. I don't think you're not supposed to put those on there. That's
no. These uncategorized. This is a healthy vaginal delivery. This needs to go part of your total number of delivery.
Numbers. Yeah. You need to get these off of here.
Yeah, get them off.
Yeah. In fact, I think all of them.
All of them should come off.
So where should they go? Like just off the list?
No. This is counted as part of your normal spontaneous. If a patient walks in, has a baby, and then goes home, that's considered a normal spontaneous vaginal delivery. That goes towards your number of normal spontaneous vaginal deliveries.
But my question is like, overall, every case goes in one, like there's a category like hypertension or diabetes or something. And for these cases, I couldn't find.
So case number, the 18-year-old gravida 1 parasite, what was her problem? Nothing.
No problem. She just came in active labor.
Okay, then that is not an uncategorized case. An uncategorized case would be somebody like, I don't know, something that doesn't fit in anything else. But these are, if you read the bulletin, it says patients that come in, have a baby, and go home are considered normal spontaneous vaginal delivery, and that's a number that you enter into your software. See, if you look up here on here, it says number of uncomplicated spontaneous deliveries. That's 50. You don't have to put those on your cases. Only the problem cases go on your case list. If you read the bulletin very carefully, and I tried to explain this to everybody when we did our first couple of case list webinars, that when you do not have if you have a patient that walks in, has a baby, and goes home, that is considered a uncomplicated spontaneous delivery and does not need to be entered as a patient on your case list. See, by doing this, what you just demonstrated to me is that you did not read the bulletin. You know, or you read Shamroth's software and he wasn't clear on it. He doesn't even understand it.
Like, for example, like it would be something like the patient has to have some sort of an
Problem.
issue that's not under that, like some sort of weird medical condition. Like, let's say that let's say that you had, like, I don't know, gosh, some sort of a strange, weird medical condition where, like, it's not listed on there. It's not like regular hypertension or diabetes or something like that. But if it's just a normal spontaneous vaginal delivery, even if it was like with meconium or something like that, it's not, it's counted in your numbers, but don't put it on your case list.
Right. See, uncomplicated spontaneous deliveries. This is that number that goes here. See, on the screen?
Okay, so even if they're not on list, just a number will go on.
The number will go. That patient falls into that category. They do not need to be listed on your case list. Go back and read the bulletin again. You need to read the bulletin again. Read the bulletin under OB case list entries. Uncomplicated spontaneous delivery is a patient that walks in, has a baby, and goes home. They have they may have had meconium staining, but you didn't have to give her PIT. She didn't have any problems during her antenatal care. She did not have to be admitted for preterm labor. She had nothing. She was nothing. She was a 19-year-old that got pregnant and had a baby and went home. Okay? You didn't have to pit her. She just walked in. She ruptured. She had her baby, and there was no problems. So that goes in here. Now, GYN ultrasound and Doppler exams, if you're doing an ultrasound and you're billing for it and you're dictating a ultrasound report and that patient's not going to the hospital and having another ultrasound, and you are the primary radiologist, then count it. Same thing with your OB ultrasounds. If you're doing the ultrasound and you're billing for it and you are dictating an official ultrasound report and not a tech is reading it, not the radiologist, then you are considered, you have to count that as a number. But if you're just scanning here really quick in the office, I would not count that, because then they're going to get into asking you about ultrasound dynamics. How does an ultrasound machine work? They're going to ask you when you see a fetal heart rate. I mean, they'll get hairy with you since you are acting like a radiologist. So I would not go there unless you are an MFM and you're comfortable about talking about Dopplers and ultrasound. Right, Liz? You agree with me on that?
Oh, I totally agree. Yeah, I mean, I do GYN only, and I have never, ever dictated a radiologic report on an ultrasound. So therefore, my list number was 0.
Yeah. So that's probably where you probably want to be with a situation like that. So, okay, so I just want to let you know. So make sure you get all those other things off your list there, all those uncategorized cases. It's really important. Okay, next candidate up is Dr. Valoria, and I'm going to, Tatiana. Hi, Tatiana, how are you?
Hello, how are you?
Good, good. Let me pull your case list up real quick.
And, you know, one thing I just want to say is that, you know, to anybody who doesn't feel that they get their case list, you know, reviewed here or stuff, Dr. Wall has a whole group of tutors that can review your case list for a couple hours. I mean, I'm one of them, but you can choose anybody. And I did it when I did my board exam. I had one of the tutors review mine, and you basically just get it corrected, and then it's done. It's very simple, and I mean, my case list honestly was perfect for the boards. You know, I had no problems with my case list, so I would, you know, it's probably the best money that you're definitely going to spend getting it reviewed for 2 hours.
Yeah, see this guy here, this is a case list that I'm doing right here. Let me just show it to you real quick. Somebody actually paid me to go get into their software and just clean their case list up for them. And I haven't done, let me do their GYN. I'll just show it to you real quick. I know we just have a couple of seconds here, but if I can pull it up. But I went ahead and I essentially what I did is I took his whole case list over, and I'm fixing the whole damn thing because it was a disaster. He had spelling errors, period signs, numbers, colons. I mean, it was a total disaster. So I mean, I don't know if I don't have time to do this. I'd love to show you guys, but what I've done to it.
Yeah, I mean, I agree with you. I mean, I basically redo the case list and just correct it.
Yeah, exactly.
I mean, I think it's something where, you know, to teach the candidate how to do it and stuff, it's better just to do it and I correct it, and then it's done for the.
I think it's done. Okay, Tatiana, is it okay if we do your GYN? Is that okay?
Oh, I wanted to do OB, but this is fine.
Okay, Liz, go ahead. I know.
All right, beautiful.
Liz's favorite topic. Okay, go ahead.
Yeah, I love it. I love it. You're a generalist, or what are you, obstetrician or gynecologist or what?
Generalist, so I do about 50-50.
Good, good. And when's your exam?
January, the first week of the 12th of January.
Oh, okay, good, good. Excellent. So you'll have plenty of time to study and to take classes and all that sort of stuff. You're going to be well prepared.
Yes, hopefully.
All right, so we'll start off with your abdominal hysterectomies. You have a 48-year-old, para 1 with menorrhagia. Okay, you can also put down menorrhagia, but just be careful. You know, they have that new bulletin out that they actually like you to call it abnormal uterine bleeding.
Okay.
So just, you know, you can keep it there for now, but I think that, you know, always make sure, go back to that handout or the bulletin and read about Palm-Cohen, okay? So you're going to have to know that for the test. And they actually asked me, you know, about it, and I said Palm-Cohen, and I mean, they just, you know, they lap it up. They like it. So
should I be, on my GYN list, should I be more consistent with that bulletin in terms of diagnosis or symptoms?
Yeah, because that bulletin has come out now. That bulletin was out even way before my exam. So, and I took my exam this year in January, so I'm pretty up to date with it. But yeah, you got to follow that bulletin with stuff.
Okay.
All right, so you can put that down. So, you know, 48-year-old, okay, you know, you probably would have done an endometrial biopsy, I assume?
Yes.
Okay, so you want to put down abnormal uterine bleeding, endometrial biopsy benign, okay, and then you put down LAVH, next line, BSO. Now tell me why that you took the ovaries out in a healthy 48-year-old. There's only a few reasons, and they're in a practice bulletin, so you got to explain yourself taking bilateral ovaries out in a 48-year-old.
You're right, and I know that the new recommendation is not to take them out unless they have like a personal history of ovarian cancer or a family history of ovarian cancer.
So she had a family history of ovarian cancer.
No, she did not. She did not.
Okay. Well, no, listen. I'm not, again, I don't tell candidates to lie, okay? But you have to have some idea of what that you need to answer to get yourself out of a hole, okay?
Right.
So again, the reasons, and we went over these this past weekend at the case review seminar. So there's a practice bulletin, and it says, you know, bilateral ovarian neoplasms. So if there was some sort of a cyst or something on bilateral ovaries, chronic pelvic pain, okay, family history of ovarian cancer, okay, that's 3 of them.
Okay.
All right. Other than that, you really don't have a lot of justification taking out this woman's ovaries, because there's more reasons to leave in ovaries than there are to take them out. Now, do I take out ovaries in a 48-year-old? Yes, because the patient is so scared of ovarian cancer. But, you know, you don't want to highlight that you're doing something that's against the ACOG recommendations.
Okay.
So tell me why you were going to say that you took out these ovaries.
I'm going to say she had chronic pelvic pain because she...
Beautiful. Okay. Next column. So benign uterus, 228 grams. You can put endometrial polyp, and then just put benign adnexa. So take out ovaries and fallopian tubes, take out benign cervix, okay?
So I don't have to put the cervix part?
No, you don't have to put the cervix, because the cervix is part of the uterus.
Okay.
All right. So this is okay for all these cases to come, because, you know, again, we have 3 candidates, and I don't know how far I'm going to get. So whenever you have a case, abnormal uterine bleeding, chronic pelvic pain, symptomatic anemia in your left-hand column, then you're going to put down you either did your LAVH, your TLH, your TAH, and then your BSO. Next column, benign uterus, the number of grams, benign adnexa, and that's it. All right, or you can put down leiomyoma if there was one there. If you're under the adenomyosis category, you can put adenomyosis in there. So you have a lot of things here on your 3rd column that's garbage, and that includes benign ovaries and fallopian tubes. Just put down benign adnexa.
Okay.
Okay.
So take out the benign endometrial polyp, or should I?
I mean, it does nothing for the case really, but she did have a polyp, so maybe that's why she had all the bleeding, you know.
Right.
But just make sure that if you have a case and it's for abnormal uterine bleeding and they were greater than or equal to 45 years old, then you did an endometrial biopsy and if they're under 45 with risk factors such as obesity, irregular cycles, and history of PCOS, that you did the biopsy, okay?
Okay, okay.
So that's what I would say for those cases. So again, you did chronic pelvic pain. So chronic pelvic pain, unsuccessful medical management, okay? I mean, the other thing that the board does not like, doctors and surgeons who take patients directly to the operating room and remove their uterus.
Right.
So you're supposed to do the things that are good for patients and that are safe. So safe means that you're going to try medical management first, then you're going to maybe try a less invasive procedure, and then you're going to, last resort should be to removing the uterus. Okay. So you probably should put down on some of these that you had unsuccessful medical management.
Okay,
or
and some of them
if,
I also had a diagnostic laparoscopy which was inconclusive. And that was after they had medical management, then with no resolution. Some people with the chronic pelvic pain that I didn't have a reason for their pain, I would do a diagnostic laparoscopy before. And some of them I also did hysteroscopy before for the abnormal bleeding, but
okay, so like for example, case number 3. So you have chronic pelvic pain, symptomatic leiomyoma. Okay, because they're going to say, well, what was the cause of your pelvic pain? Was it endometriosis? Was it the leiomyoma? I mean, yeah, I have patients with pain too, and they're just crazy, and they just want their uterus out, but you can't give that as a reason. So next
so even, I'm sorry, so even though like I found the real reason at the time I received the pathology, because I'm making this list, then I can say, okay, this was indeed symptomatic fibroids. Okay.
Chronic pelvic pain. So your chronic pelvic pain is going to justify taking your ovaries out here. All right? So that's going to give you a point right there. Symptomatic leiomyoma, TAH, BSO, exactly how you have it. Benign uterus, 302 grams, leiomyoma, adnexa benign.
Okay.
All right, and then she's 46, so okay, that's fine. All right, so now you have a 48-year-old, again with abnormal uterine bleeding. You can put chronic pelvic pain or symptomatic leiomyoma. I mean, you had adenomyosis in the pathology here, so I think that's good enough. So you did an LAVH, don't put a slash, put next line, RSO. Then in your next one, uterus 180, benign uterus 186 grams, leiomyoma, adenomyosis, benign adnexa. Okay?
Okay.
All right. 40-year-old P2, so you have abnormal uterine bleeding, symptomatic anemia. Okay, what do you got going on here? An endometrial polyp with a foci of hyperplasia with atypia. You misspelled endometrial.
Oh, okay.
Yeah, really watch for spelling mistakes because you do look like a sloppy doctor if you have spelling mistakes. All right, and forget about the distant history of DVT. Cut that out. Then you have TAH. Okay, and you left in this woman's ovaries?
Yes, because
okay, that's fine.
To be honest,
no, that's fine that you left her ovaries in. I wanted you to. So take out, why did you take the tubes out? I know why you're going to tell me you took the tubes out. You took the tubes out because to decrease your cancer risk because of that study, right, in GYN oncology, but that's not standard of care yet, okay? So unless you know that study backwards and forwards, and it's my opinion that you not quote studies to the board examiners because they're smarter than you are, and they wrote the studies, that I would take that out and I would put just TAH, take out bilateral salpingectomy, take out DVT prophylaxis, benign uterus, however many grams it was. You didn't put the grams.
Yeah, I know. I have to look that one up.
Okay, well, don't forget, all right? And then leiomyomas, adenomyosis, and that's it. All right, so all your days look good. It stayed in the hospital, let's say 3 days, 1 day, 3 days. Okay, so that's good. All right.
Okay.
So let's go ahead down here. Take out benign fallopian tubes.
Okay.
Okay, so laparotomy. So a G6, P6, so, okay, so you did this for uterine attempted LAVH converted to laparotomy due to adhesive disease. So what did she have? Multiple prior surgeries, or what happened on this patient?
Yeah, she had 2 or 3 prior C-sections. And so when we entered the abdomen, she had dense adhesions of the bladder onto the anterior uterus, some momentum on the sides of the lower uterine.
Wait, so you did this hysterectomy for prolapse, and all you did was remove the uterus, and you didn't do any support?
I have to look at the records to see exactly what we did. It was a complicated case where we actually had to call in the surgeons to help us with this.
No, you are the surgeons. You didn't have to call on the surgeon.
I'm sorry,
you are the surgeon.
Yeah, I know. I meant for
I just have a problem with you doing a hysterectomy for the reason of uterine prolapse, and then you provided the patient no support with anything. I mean, they're going to be like, what the heck is going on here? What is this doctor? I mean, I think that Dr. Micheri, I think she's got to provide some sort of you got to do some sort of a
uterosacral ligament suspension.
Yeah.
I mean, just put, we all titled uterosacral ligaments together. Just put uterosacral ligament suspension.
Yeah, you got to have, I mean, if you're giving us the reason uterine prolapse, you got to do something urogyne, okay?
Something.
Okay.
Something. So, or change it that you didn't do it for uterine prolapse, that you did it for chronic pelvic pain because of her adhesions.
Okay.
All right? So it's either one or the other. Okay, so you have a TAH, next line, BSO, next line, lysis of adhesions. So, okay, I would go back under the diagnosis. I would put uterine prolapse is okay, but make sure that you study the Baden-Walker and the POP-Q, know which one that you use, and even if you use Baden-Walker, you have to know POP-Q. So you're not getting out of it, especially if you have prolapse on your case list. So I would put down uterine prolapse, history of multiple abdominal surgeries, unsuccessful LAVH, and then next line TAH, next line BSO, next line lysis of adhesions, surgical pathology. Oh, and then don't forget you got to add in some
uterosacral ligament
support.
suspension.
Yeah, uterosacral ligament suspension. Add in that you supported her. Benign uterus, 100 grams. Leiomyoma, adenomyosis is misspelled, and then you have benign ovaries, benign adnexa.
Benign adnexa. You don't need to put all this there. Benign ovaries and fallopian tubes. It's too much.
Okay.
Okay?
And, okay. I don't believe that a converted laparoscopy is a complication. I convert a lot of my laparoscopies that I feel that I can't do, and I don't list that as a complication in my surgery.
Okay.
Yeah, it's not a complication. Okay, 31-year-old, G2P2 with chronic pelvic pain. I would again put unsuccessful medical management, be able to explain, oh gosh, a supracervical hysterectomy. Why did you do a supracervical hysterectomy?
Because we had a lot of trouble getting down to the end of the cervix. She had a very long cervix. So because she had a normal path,
Yep.
I rarely do super cervical, but it was a very difficult case. So
did she have history of multiple abdominal surgeries?
Yes.
Okay, so you put that in the first column. Treatment, you can put down supracervical hysterectomy. Don't hyphenate that. Take out the bilateral salpingectomy. You can put lysis of adhesion. So that's how you're gonna justify a supracervical hysterectomy. Okay, that's one of the reasons that you can justify it is for patient safety with all the adhesions, inability to safely remove the cervix without creating injury to the patient. So for the patient's safety, however, that wasn't, so don't say though that that's how that you consented the patient for the surgery. So you consented her for a total abdominal hysterectomy, and then at the time of surgery, for the safety of the patient, you elected to perform a supracervical hysterectomy due to severe adhesive disease.
Correct.
All right. So benign uterus, 74 grams, adenomyosis, that's fine. Did you take out her ovaries?
No.
Okay. So, yeah, she's 31.
Yeah.
Okay. Okay. Complications, none. Okay, good. All right. I'm going to let Denise tell me when I need to go to the next candidate.
Yeah, I will. Don't worry. No, just
Okay,
keep on
good,
going.
good.
Keep on going
Good, I'll
until
keep
10. Yeah, keep on going.
Perfect. I'll keep rattling my mouth. Okay. G2P2 with chronic pelvic pain, 34 years old. So you did a diagnostic laparoscopy. You need to
Fix that. Okay.
Yeah. I just
see
noticed
it
you're
now.
spelling all your laparoscopies. Yeah, make sure and change that, and keep your capitals all consistent with a small L.
Oh,
Okay,
okay.
same thing. Chronic pelvic pain. Yeah, don't make it look nice and neat. Okay. Laces of adhesions, none. Chronic pelvic pain, dysmenorrhea, diagnostic laparoscopy. Let's see, allergy to chronic pelvic pain. Okay, I think those are okay. Those are fairly simple. 34-year-old, chronic pelvic pain, menorrhagia. Okay, so you did an ablation on this lady. So you have to have a endometrial biopsy. So I would put chronic pelvic pain, abnormal uterine bleeding. I would put benign endometrial biopsy, and then diagnostic laparoscopy, laces of adhesions, hysteroscopy, DNC, uterine ablation, and that's fine. You can put a benign endometrium, that's fine. So with these ablations, which ablation do you use?
I use the Novashore.
You always use the Novashore?
Or the balloon ablation. But mostly the Novashore. For these patients, I use the Novashore.
You use that, but do you use that for every single patient, or do you you don't use the same thing for every patient? What I'm trying to get is that you individualize every patient, okay, based upon the size and the shape of their uterus, because there's contraindications to every type of ablation.
Correct.
Like, you know, for example, like with, like I use the HER option primarily, but if the patient has a 3-centimeter fibroid impinging upon the cavity, I'm not going to use it. All right? So you don't want to just say that you use the same ablation for every single uterus no matter what.
No, I
that
meant
means
for the
that
patients on the list.
Yeah, I know what you mean, but just make sure that you know the different types of it, because if you have ablation on your case list, which we all do, make sure and that you read there's a practice bulletin on all the different types of ablations, and you have to know the indications and contraindications for each ablation type. Okay. And just because that you don't do them doesn't mean that you don't have to know about the others.
Okay.
All right. So operative laparoscopy, a 56-year-old para 2. She has a family history of ovarian cancer. So she did a BSO in her, and it's benign adnexa, right?
Oh, yeah, benign.
So did you do a laparoscopy, or was this open? Oh, I'm sorry. This is under laparoscopy. I see. Sorry about that. Okay. Okay. Don't forget, just make sure and justify her family history. I mean, know it. It's not just some aunt, you know, that distant
So should I
had ovarian
should
cancer.
I write the family history there, or just be prepared?
No, I don't think that you should. I mean, you can put strong family history, but I mean, I think that, you know, you don't want to just take, so a lot of patients, here's the issue, you have a lot of patients come into your office and they're all scared of ovarian cancer, okay? They all read the Time article about Angelina Jolie and the BRCA mutation, and they all come into the office and they all want to be tested for it, and they all want their ovaries removed. But, you know, you don't take every patient that just wants their ovaries removed because their great aunt had ovarian cancer at the age of 90. So you just have to make sure that you really go through the counseling process and make sure that you know that patient's family history, because you put it on your case list.
Of course.
All right? Okay, so next one, an operative hysteroscopy, a 31-year-old, G2P2, an embedded intrauterine device. So I probably would call that a retained IUD. Then I would put operative hysteroscopy, and I would put removal of IUD. And I know Denise already has that circled, I think, so that's good.
And IUD, an approved abbreviation?
I believe that it was.
Yeah, it is. It's approved.
Yeah.
Okay.
Okay, good. So that's that for that case. Okay, so uterine myoma, so you have a 44-year-old G4P4. Okay, so you want to do abnormal uterine bleeding, symptomatic leiomyoma, okay, next column LAVH, next column benign uterus 140 grams, leiomyoma, and then get rid of benign endometrium and benign cervix.
Okay.
Okay, all right. So you have now your ectopics, which they will for sure ask you. Okay, so you got to know the management of ectopics. 33-year-old, para 3. Okay, so you took this patient for a laparotomy, so I would put acute abdominal pain, positive, but you could put down vaginal bleeding, positive beta HCG. What did you put down with this pelvic ultrasound, no intrauterine pregnancy? So I would put down like 2 or 3 centimeter adnexal mass. And you could put down also hemodynamically.
Well, they didn't see that because she was ruptured.
Oh, she was ruptured. Okay, well, you can put down hemodynamically unstable.
Okay.
Next line.
Instead of dropping hematocrit?
Yeah, because it tells more of a story. Like a drop in hematocrit, okay, did she drop 0.5? Did she drop 1? I mean, hemodynamically unstable is a sick patient in the emergency room, like that needs a laparotomy stat. Okay? So then you justify, I mean, it's, again, you know, you don't have to take the patient for a laparoscopy. You know, if you have a person who's not, let's say, does not feel comfortable doing a scope on a ruptured ectopic, it is well within the standard of care always to do a laparotomy. I just did a laparotomy like 3 weeks ago on an unstable patient, you know, whose hematocrit did drop, as you say, you know, significantly. So, I mean, you don't have to don't feel like that you have to justify really doing a laparotomy, but you do have to justify taking the patient to surgery.
Okay.
Okay. Then you can put salpingectomy, good. I would get rid of the cystectomy, and you can put down, let's see, what column are we in here? What column do I want you to put transfusion? I think I want you to put it under the complications.
Okay.
So do you see up here, it actually says complications including blood transfusions, okay? See?
Yeah, I see that. The reason I put it on the treatment is because we transfused for treatment of her hemodynamic instability, and it wasn't, she didn't bleed due to the surgery, so that's why I was confused as where to put.
Well, I would say put the transfusion where it says include blood transfusions. That's where I put it on mine.
Okay.
And then going back up here to the rest of this thing, you misspelled chorionic. Here.
Okay.
And then, so they might ask you, why did you remove this young woman's tube? So there's
I'm sorry, what was your question?
Why did you remove this woman's tube? Why didn't you do a salpingostomy?
I did a salpingectomy because her tube was ruptured already.
Okay, and you felt that the blood loss was acute, right?
Yes. And I felt that the tube was very damaged.
Okay. All right, good. Just have a reason. And then one of the other reasons is sometimes if you have like let's say if they change the case up on you, you know, you could always, like let's say they said, okay, she's not ruptured. So this is what they do on the boards, okay? So they'll change the case up around and then you don't have an answer anymore. Well, one of the things that you can say is that like you can always justify taking the tube in a young woman by saying that there was severe adhesive disease.
Okay.
So you can always say, you know, because there was severe adhesive disease, I had to take the tube. It was, you know, I didn't have a choice. All right?
Okay.
Okay. So next one, let's see here. You have a young girl, 17, difficulty with tampon, T-A-M-P-O-N, insertion, good. Intermittent swelling of the vagina. Okay, so you did a hymenectomy. Fenestrated hymen and a normal introitus. I don't know if I would bother putting down normal introitus, actually. I like this case. This was actually, I had this exact case on mine, difficulty inserting tampon. So I would put down, I would keep it at that, and I would take out normal introitus. I mean, it doesn't really give much, and it's not really in the pathology either. So.
Okay.
Yeah, an introitus is not a pathologic report. Okay, so a 16-year-old, an imperforate hymen. Yeah, make sure that when you talk about these different hymens, that there's all these different types of, there's, imperforate, there's different types. So make sure that you look that up, because they could switch it on you and they could switch it to a different type. Okay?
Okay.
Hymenectomy, evacuation of hematoculpus. Okay, and you can just put, none under surgical pathology
Okay.
instead of NA. Okay, so you have abnormal uterine bleeding. I am not sure that PMB is an approved abbreviation. You might just check on that. It might be, but
No, I
just
don't think it
recheck on
is.
that.
I think I hit the right.
I don't think it is either.
Postmenopausal bleeding. I would just put abnormal uterine bleeding for all of these.
Okay.
Okay.
Yeah. I mean, if she's 68, I think it's pretty self-explanatory that it's, so abnormal uterine bleeding, okay, you did a biopsy, or what did you do? Go straight to a DNC?
I went straight to hysteroscopy and DNC because she did not tolerate biopsy or
Okay,
exam
so
in the
you can
office.
put abnormal uterine bleeding, stenotic cervix, next column, hysteroscopy, DNC, next column, simple hyperplasia with atypia. Okay, now you're giving this woman with atypia the progesterone? So I would look this up,
Yeah, because she refused surgery.
You don't have to put the progesterone on here. I'll be honest with you, because you're kind of opening up a can of worms with your management of hyperplasia with atypia. So let them, if they want to ask you about that, then they'll ask you about that, but I would leave off that progesterone and just put that was, simple hyperplasia with atypia. You have simple hyperplasia with atypia, huh?
Mm-hmm.
It wasn't complex?
No.
Okay.
That's why, I advised her of the recommendations of hysterectomy, and she asked for more options. I said, well, I prefer you to have a hysterectomy, but you can do progesterone because it's simple hyperplasia. And she did not want surgery.
Okay, even though, okay. All right. So the next one, you have a 40-year-old G2P2 with abnormal uterine bleeding. You did a biopsy, I assume, ahead of time because you're doing an ablation.
Yes. Yes.
Yeah. No, there's no. You do it.
I
do.
It,
Yeah.
I put it here also under the pathology. I have to add the.
Okay, so whoa. Okay, so you're telling me you did a biopsy on a patient ahead of time, and it showed simple hyperplasia with atypia, and you ablated her?
No. Hold on, I'm just looking at the case to see. No, looks like I did a DNC and hysteroscopy at the same time. And then, I think the same day I did the endometrial ablation. So this patient, when the pathology came back simple hyperplasia with atypia, I did a hysterectomy on her. So she's on the list for hysterectomy as well.
Oh, but you can't have the same patient on the list again.
Even if it's a different procedure?
Yeah, even if it's a different procedure, you can't put the patient on the list twice. She has to be doing one or the other.
Yeah, I would cut this one out because I don't like ablation associated with hyperplasia with atypia.
Okay.
All right. I mean, I think that I would take this one out, and then you can keep in your hysterectomy one.
Okay.
All right. Okay. P4, again, abnormal uterine bleeding, benign endometrial biopsy. Wait, so she's 23. Hold on here. Okay, so so tell me about this patient. So you took her.
So this is a patient that she, after her last baby, had abnormal uterine bleeding. She tried oral contraceptive pills. Then she stopped them herself. She did not want to take any oral contraceptive pills. She had an IUD placed. She wanted it out. She refused. She didn't like it. And she continued to have abnormal bleeding. So on her ultrasound, there was some echoic, hyperechoic, I forget, I have to find her ultrasound, on her endometrium, a hypoechoic lesion. So I said, okay, so let's do a hysteroscopy and DNC. Maybe we can find the reason of your bleeding. But it came back benign. She was refusing any other kind of medical treatment, so that's the only reason I did a DNC. And since I was doing a DNC, I might as well do the hysteroscopy.
Yeah, there's a little bit more to the story then. I mean, it's not that just like, you know, because now the next patient, I see you're taking another 23-year-old to the operating room.
You know what? So that's the same patient. So I didn't know that you can't put the same patient even if it's a different procedure. So then.
Wait, this is a 23-year-old para 4, huh?
Yep.
Okay.
And the only reason I did an endometrial ablation is, even though I told her, I advised her of all the other medical options, she's like, I know I don't want a baby. I had a tubal ligation already. She had another provider do a tubal ligation before I met her.
Okay, so first of all, you misspelled endometrial, but let's go back. So you got to combine these cases into one because you can't put the same case twice. Okay, even though it was a different procedure. So that goes true for all the rest of your cases on the case list, because I know we can't go through these with you, you know,
yeah, I
everyone
think these are the only two that were like that.
So let's do this. Okay, so let's put a 23-year-old para 4. We're going to put down abnormal. You're going to put down in her persistent abnormal uterine bleeding. I would put down something like complex echogenic focus on ultrasound. Okay. Unsuccessful medical management, and that's what I would put down for her. Okay, and then the next column I would put hysteroscopy, DNC, uterine ablation. In the next column I would put down benign endometrium.
Okay.
I mean, because there is a small justification, you know, there's always lines in the abnormal uterine bleeding protocol that any patient who has persistent abnormal uterine bleeding, you have a justification to take her to the operating room, just as you have a justification to scope somebody that has chronic pain. All right?
Mm-hmm.
Okay.
We're going to have to stop there because I need to go on to the next candidate. So next person up is, find the next person. I have to, okay, Dr. Letgo. Hi, Dr. Letgo, are you there?
Hi, how are you?
Good, good, excellent.
So, hey, how are you tonight?
Good. How are you?
All right, so tell me about yourself. When's your exam? Are you a specialist or generalist or what?
I'm a specialist. I do GYN and Urogyn.
Ooh.
Oh, what fellowship did you do? Just you did Urogyne fellowship, right?
Urogyn, yeah.
Okay, so you're OB. Good. Oh, I love specialists.
I know. You want to do OB list, Liz?
How many do you have for your OB list?
20 from residency.
20 from residency, right? Yeah, and 20 is okay, all right? So don't feel, okay, you misspelled breach. I already see that. Okay, so don't feel shy that you only have 20, because I actually called the boards and I did the same thing. So I did a minimally invasive surgery fellowship, and I actually called and the woman said, just put 20, just pick 20 from your residency. So you're going to be good with that. And then you probably have a lot of GYN cases from fellowship?
I don't have any fellowship cases. I have all my, this was my first year as an attending.
That was you're an attending. And how many GYN cases then do you have?
I had I put 36, I believe, or 40, somewhere there.
And you know, and that's fine. I mean, I also did not put my fellowship cases. I put my attending cases, and I had 20 OB and about maybe 40, 35 to 40 GYN. And they're going to say, well, you know, you might think, oh my God, you know, like I'm a specialist and all that. But you know, when you just start out in your practice, you're not like doing a bunch of surgeries. You're seeing a bunch of annuals, you know, and you have to get surgery. So I don't think there's anything wrong with a case list like that.
Okay.
All right, so yeah, so we'll go for like whenever Denise will stop me, we'll keep going, okay? All right, so 21-year-old, gravido 3, para 1, she's at 38 weeks. Okay, so I would put breech presentation, I would put active labor, and then take out prior cesarean delivery, none, and then repeat cesarean delivery without the period at the end. Okay, so it looks to me like you put a period after everything.
Yeah.
Okay, that looks kind of sloppy because it's not a sentence. Okay, and you have 3 days in the hospital, 2,600 grams, 9/9 in 3 days. Okay, good, that matches. A 29-year-old.
Sorry about that.
Well, that's okay. It might activate my dog though. Okay, 29-year-old G3P2 at 34 weeks. Okay, so you have breech presentation, preterm labor. Okay, you don't really need to put this gestational diabetic because she's in preterm labor and she's breech, and that's why that you sectioned her, right?
Yeah.
Yeah. I mean, because she kept, what did she have? Did she have PPROM?
Sure.
No, I mean, I'm just, no, yeah, I mean, you know, you can put down PPROM or whatever that she came in with, and just know your management, though, you know, for PPROM at 34 weeks, okay, with a breech. It's none, and then primary cesarean delivery, take out the period, 3 days in the hospital, 2940, 8. So the baby stayed 8 days, right?
Right.
And then why would the baby stay 8 days? Give me some reasons on why a premature baby would stay 8 days.
Meconium or...
No, they generally don't stay for, well, kind of. But so the reasons are respiratory distress syndrome, primary pulmonary hyperplasia, or PPN, and interventricular hemorrhage. So just make sure that you know the baby's complications of a preterm delivery, right? Because there's baby complications and there's mother's complications, right? So make sure that you have things nicely laid out in your head so you can explain them. All right, complications of a C-section, a 34-year-old at 39 weeks, cesarean delivery ×3, history of bowel injury repaired during prior cesarean delivery. Okay, this is very messy, and I can't understand this case at all. What happened here? Just describe it to me.
As far as I remember, there was a woman who had 3 C-sections before.
History of, right?
History of C-sections. Yeah, prior to that, with the last one, she had a bowel injury.
Okay, I don't care about the last C-section that she had a bowel injury, so you can take that out. So you can put history of cesarean CD ×3, okay, and then cut out the history of the bowel injury, okay, and then enterotomy.
Yeah, so during the C-section there was another enterotomy.
Okay, so then the next column under operative procedures you can put repeat cesarean delivery, and then you can put small intestinal resection end-to-end anastomosis. Let's see. I don't know about putting all that. I would put small intestinal. You could put small bowel resection.
Okay.
I think that you know, just make sure that you know about how to repair the bowel.
Well, why would I? I mean, there was a general surgery who did that.
I know, but it doesn't matter. You're a surgeon, so I mean, you're going to have to know somewhat how to explain how to repair a bowel injury.
Okay.
Okay. So, I mean, you can't say, well, why would I have to know that? And first of all, don't ever say that to the board examiner, okay? So, perpendicular to the long axis of the bowel, okay? And in all of the courses that Dr. McSherry has, we teach it and we show it to you and stuff like that. So make sure and either get her handout or really go through that, because you do have to know somewhat how to repair a bowel injury. You can say, you know, I would do this, I would first call in a general surgeon. They're going to say general surgeon is away at an emergency. I mean, so you do have to know somewhat how to explain it.
Yeah, I mean, and I do. I mean, this is for I mean, there was a severe injury of the bowel. You know, there's more than 50% laceration.
Okay. Sorry, I'm trying to just page down here. Okay, maybe I went a little bit too far up here. So for some reason I can't get up. Oh, there we, okay. So this one, antepartum, 39 weeks. She came in labor.
Which case are you? Oh, number 4?
I'm on the next one. It's just a little bit slow paging down, but it looks like that you, she's in 39 weeks and she came in labor, right? So you can put down active labor, category 3, fetal heart tracing, intrapartum fever, antibiotics, primary cesarean delivery. Got it?
Yeah.
Okay. Next one, induction and augmentation of labor, a 32-year-old, pair 3 at 40 weeks. Latent labor, GBS carrier. Okay. So, okay, did she have a protracted first stage? I mean, that's what it looks like. So it looks like that she had a protracted first stage, okay. None, and then take out the continuous maternal fetal monitoring, take out the antibiotic prophylaxis. You can put down augmentation, and then you can put down SVD. So the patient either should have, like, if they have an arrest of dilation, an arrest of descent, so arrest of descent goes under the delivery, arrest of dilation goes under the antepartum, protracted first stage goes under the antepartum, okay? So I mean, I'm not sure exactly what this patient had. I mean, you can tell me if you want, but...
Sure. Yeah, I mean, she had protracted the first stage of labor, and I mean, she was just augmented, basically, and I mean, delivered.
Okay, okay, got it. So 3,400, 99, good 3 days in the hospital. Okay, so a 19-year-old at 40 weeks. So I would say that she had severe oligohydramnios, none. Just put induction. You don't have to put induction of labor, and then put SVD. 2 days, 3290. Okay, that's good and appropriate. Okay, infections complicating pregnancy. I see. So you're saying that this was like an antepartum, like before that she went into labor, or what? How did you find this trichomonas?
Which case? No.
This is case number 7.
She was complaining of discharge, vaginal discharge.
Okay.
And then, I mean, we did a culture, and that came positive.
Okay, so you induced her for severe oligo or for the trichomonas?
Oligo, yeah, of course.
Okay, okay. So you kind of just put this under an infection.
Yeah,
You know, I don't...
This was a history, basically, during the pregnancy. I mean,
You know what I like better is I actually like your case, and I don't want to page back up there because I don't want to mess up, like, seeing what we have here. But, like, you had a case up there of choreo. You know, the intrapartum fever one? Why can't you put the intrapartum fever one under this one? I mean, that's what I would do.
Well, then I'm not going to have another. Oh, I can actually, yeah.
Yeah, yeah. I mean, that's what I recall up there.
Okay.
All right. Okay. Medical and surgical complications of pregnancy. Okay. 24-year-old G through 41 weeks. She had hyperthyroidism. I would put hyperthyroidism without the period. Active labor done. SVD. And I would put, I wouldn't put endocrinology consult because they really don't like to see you ordering a lot of consults. If you want to put down, I mean, these are ways to put it down, I think, that make you look a little bit better. So you can put co-management with endocrinologist. You can put appropriate thyroid level control. So you can kind of put something that makes you look like that you did something for your patient, that you just didn't like throw her off the cliff to the endocrinologist. All right, so something like that. You can pick what that you want, but don't misspell or endocrinology consult. Okay, all right. Okay, so multi-fetal pregnancy, moving along. So you have a 29-year-old G1P0 at 36 weeks. Sorry, it's just taking a little bit to page down here. I already don't like, though, the baby A and hydramnios. So I think you have twins here, right?
Right.
Okay, so I would put down twins. And then under the delivery, how did you deliver them? What did you do? Did you section them? I'm sorry, I can't just, it seems slow going back up.
Yeah, she had primary cesarean section.
Okay, so I would probably put down twins, and I would put down labor, and then I would put down none and primary cesarean delivery. And then let them ask you about twins, the different types. So, you know, for you, just one bit of advice that I would give you coming from me who, and you can even ask Denise, when I went to her first review course, I had an examiner ask me, what are the stages of labor? And I didn't know that answer. So, I mean, if you've been away from obstetrics, like you are very, I can tell the way that you answer questions on obstetrics, you're a little bit weak, which is natural, okay? But what you have to do is you have to make sure and go a little bit above and beyond than studying obstetrics. So whether it's taking a lot of review courses or whether it's reading Williams Obstetrics, or whatever you feel that you need to do, you have to do it because you have to talk and speak like that you're an obstetrician, not a urogynecologist. And I mean, you can say it once, like in your obstetrical session. You, like if they ask you like a really complicated obstetrical question, you can say, you know, I probably, given the fact that, you know, I'm a minimally invasive surgeon, I would probably co-manage that with a higher risk obstetrician. And then they'll get it. You know, they'll know. One time you can say that you're a urogynecologist and then that's it. But you have to speak at the level as if you do obstetrics every day. All right? So that's what I would do with these twins, but make sure that you look at, there's a nice handout, I believe it's in Dr. Wall's study guide, that it has the twinning all laid out. It's really nice on what days the twinning splits and all that. All right, so do you have any questions so far, by the way?
No, I'm okay.
Okay. A 17-year-old, para 0, so she's at 31 weeks, preterm labor. Oh, and this is twins too, huh?
Yeah.
Okay, so I would put preterm labor, twins, and then I would put down, take out your continuous fetal heart monitoring. Let's see. I would put down antibiotics, steroids, magnesium sulfate, take out the tocolysis, and then you can put down twin A, SVD, twin B, cesarean, CD. That's fine. I would probably take out all that middle crap. Twin B, breech, maternal anemia, asymptomatic. I mean, if it's asymptomatic, why put it on the case list?
Would you put anything there? Or?
No, I would probably put down none. But you delivered twin B because she was breached. So you could put down let's see, where would you put down? So you could put down preterm labor, and you didn't do like a internal version, you converter or something?
No.
No, okay. You know, I would just leave it at that. Like, let them ask you what that you did, how did you manage an operative twin delivery. But make sure that you know how to manage it and that you've read about it.
Sure.
You have read that section in Williams on twins. Okay, it's really important. Because if you don't do obstetrics, you're going to get really nervous when they ask you obstetrical questions. 43-year-old, so this is case 11, 43-year-old, P7 or G7 pair 3 at 39 weeks on methadone. Okay, I would put precipitous labor. You can put down positive urine toxicology, take out on methadone, take out for cocaine. You can put down
substance abuse. You can do that.
Yeah,
or
yeah. You know what?
Substance abuse.
Yeah, yep. Yeah, I like that better.
Yeah,
That's a nicer
substance
way to.
abuse.
Yeah. And then I don't know if I would put under the middle column a neonate SGA. I mean, I don't know. Would you put that under there, under that, Denise? Neonatal SGA?
He could. He could. If a patient was on cocaine, he could put neonate below the 10th percentile for growth or something like that. I think it's okay. He could put neonatal small for gestational age.
Yeah, I would put down neonatal, and then, I mean, you have a reason for it. You know, you have a reason for it, the coke. So, and then SVD, okay, 99, good. And then we'll do like one more. Is that okay, Dr. McSherry?
Oh yeah, just one more. Just do this last one, then we got to close up here.
All right, so G2P1 at 36 weeks, so she's got preterm labor. Okay, so I would just put, okay, preterm labor, get rid of the vaginal bleeding, none. I would put augmentation, vacuum delivery. It's a failed. Okay, so unsuccessful vacuum delivery.
Or unsuccessful operative delivery, or don't even put that and just put primary CD.
Yeah, it depends upon if you want to get into the route of talking about operative deliveries. If you studied vacuums a lot and you know everything about them, then you can put it. But if you don't, then, I mean, it doesn't mean they're not going to ask you that anyway.
Okay.
So yeah, and then primary CD with no periods. Okay?
Okay.
Just be sure and study that. It'll be real hard, okay?
Okay.
Okay, thanks, Liz.
You're welcome.
I appreciate everything you did for me today. It was awesome. Thank you very much. Okay, this is Dr. McSherry concluding tonight's webinar. It is 10:28 p.m. on July 14, 2014. And then tomorrow night we have 3 more candidates, Dr. Consoli, Dr. Onar, and Dr. Ashfaq. And I think we may have one candidate that may have canceled for tomorrow night. So I do have a, if anybody would like their case list reviewed and has not had their case list reviewed, please let me know. And then if they have and nobody volunteers, then I can put in a 3rd request tomorrow night. Okay, take care. Have a good night. And we'll see you all tomorrow. Good night now. Oh, remember, we do have a case list course this weekend in Newark, New Jersey. Take care. Thank you.